There we go. Welcome, everybody. Thank you for tuning in today for Dr. Hammer's discussion on updates in kidney cancer. There's a lot of things to cover today. We're going to start with some slides from Dr. Hammer's, and then we're going to get into a Q&A session. So as we're going through the presentation, if you do have any questions that come up, please don't hesitate to type those into the chat box or just save them for the Q&A session, and we'll make sure they get your questions answered before we wrap up today. This session is being recorded, so you'll be able to find this conversation on our YouTube channel as well as our website. And this is a follow-up to a conversation that we had with Dr. Hammers back in 2019. So if that focused a lot on immunotherapy and some clinical trials surrounding that. So if you guys wanted to revisit that, you'll find that on our YouTube channel as well. So Dr. Hammers, thank you so much for joining us today. How are you, sir?
Doing well. Thank you, Scott.
Well, I'll go ahead and turn it over to you. Please give us a little bit of background on what you're doing at UT Southwestern.
Sure. So Scott, I'm a medical oncologist. I obviously focus in GU, but primarily actually in kidney cancer. And so I'm a clinically oriented, translation oriented investigator, and I see a lot of kidney cancer patients and have a strong interest in immunotherapy, etc.
Fantastic. So what's the latest? What you got for us, doctor, today?
I wasn't sure what to talk about. So, so I just grabbed some things that, just to illustrate a little bit how we are thinking. Talk about some clinical trials that are currently ongoing, just a couple, just to make patients think about clinical trials first, so to say. And then I have some personal interests. May not be of interest to everyone here. I will browse kind of like quickly through them. And I think the main portion, from my perspective, should probably be the question-answer session, and we can dive into some topics that are of particular interest. I already just talked to Deb Mask, and she would like to talk about adjuvant therapies, etc. So I think there will be lots of opportunities to give you my thoughts.
Awesome.
Good. Do you want me to start?
Yes, sir. Take it away.
Okay. Sounds good. So, welcome, everyone. I'm excited to be here again and talk to you guys. And again, thank you so much to the Judy Nicholson Foundation for hosting me. Let me see. Oops. So these are my disclosures. We all do clinical research, and I think it's good to talk to companies to keep them in the range of things that that's important, how to move things forward in a way that makes the most sense, quite frankly. So again, my bias here also is clinical trials first. Think about clinical trials first. I know it's really hard, especially I would say for patients who were just diagnosed. Often they are scared and just want to start therapy, etc. So it's very difficult for them to sometimes, take a step back and say, hey, let me get all the information to make a decision. And maybe there's something better in the form of clinical trials potentially than the currently available standard of care. So the worst thing I think for all of us in the academic world is if a patient comes for a second opinion, but just started the first pill or infusion, etc., and then there are not really that many options for us except until disease progression. So again, clinical trials first, no matter where you are in your disease state. That's a little bit of one of my suggestions. I would say there are two major trials going on. This is a phase 3 trial. I think that will most likely have a significant impact on the field. You already heard of Cosmic 313, and we can dive into this. It's another triplet therapy upfront trial with cabozantinib, nivolumab, ipilimumab. This is the Merck version of it, if you will, has 3 arms. It's for clear cell renal cell carcinoma patients who are untreated. And the comparative, if you will, is lenvatinib pembrolizumab, is one of the more potent PD-1 TKI combinations. And the other 2 arms either add an additional immunotherapy, a CTLA-4 inhibitor. So similar to, we think about nivolumab, ipilimumab, for example, it's the Merck IPI component, if you will, or belzutifan, which, as many of you know, is a very exciting small molecule. By the way, that came out of a spin-off company from UT Southwestern that's uniquely well tolerated and targets the way clear cell kidney cancer thinks. So that's an interesting clinical trial, again, for untreated clear cell renal cell carcinoma patients. For those of you, who know people or are involved with non-clear cell kidney cancer, that's a more challenging space. But this is, if you will, the cosmic 313 of non-clear cell kidney cancer, a study that has grown in size and number, led by Brad McGregor from Dana-Farber. There are currently 2 sites. I think there will be more coming that are enrolling. One of them is UT Southwestern. The other one are 3 sites up in Boston. And so to me, it's a very interesting trial. It's a more challenging patient population with metastatic disease than clear cell. But I think, if you wanted to be aggressive and go sort of say full in, there could be an interesting option for some patients, again, untreated non-clear cell kidney cancer. The other theme that, I like to think about is, how can we make immunotherapy more effective? And the truth is, some patients will do extremely well with immunotherapy and others will have virtually zero benefit. And I think the main differentiator is that in some patients, the cancer is visible, the immune system is involved, and others have essentially non-inflamed tumors. And you can throw as much immune checkpoint inhibition on these patients. Nothing, unfortunately, is going to happen. And so one of the goals is really to inflame tumors. One of the studies that we've done that went into that space to see if we can maybe induce some inflammation was a study that we presented. I remember that quite vitally because it was really just before COVID came, the COVID lockdowns came at GU-ASCO in 2020, where we combined stereotactic radiation with nivolumab, ipilimumab. So essentially classic nivo-ipi treatment, and then we had stereotactic radiation, fairly high dose. We picked one lesion, and the hope was you radiate one lesion, and then maybe you educate the immune system, and maybe you can increase the response rate. Most of the lesions radiated were lung metastases, but also lymph nodes. We had some bone, and some patients had an easily accessible, often larger kidney mass. It was overall well tolerated. The toxicities, in the range of what we would see with dual immune checkpoint inhibition, so a higher rate of corticosteroids, and also the patients who could not get all 4 doses in similar range that we would see with this particular therapy. The response rates were actually quite encouraging. If you look at just at the very first scan, we saw actually significant shrinkage in 68% of patients, but when you confirm the response, meaning you want to still see that on the next scan, came down to 56, but still a number that was higher than we would normally think about with just nivo-ipi alone. And so that was a small study, 25 patients, so it's certainly not definitive. There was no control arm there. But I think the thing that we could learn from it was, A, it's feasible, you have also acceptable side effects, and we felt there was enough of a signal to potentially pursue that further. And so we will have, hopefully soon, it's been a long journey, I think partly also through COVID, and then working with a drug company to get some of these access, is RADVAX2, where we essentially on the right side is depicted a PD-L1 PET, where we will essentially do PET PD-L1 imaging with a small molecule from Bristol Myers Squibb. And then we will find out tumors that are actually not inflamed, right? And instead of radiating a tumor that's already inflamed, you actually want to radiate something that is not inflamed, because most of the time you actually have heterogeneity of disease. So if you look at the little graphic human in the middle, not all the deposits look the same. And the truth is some of them will be inflamed and potentially disappear with immunotherapy because they're already hot. And others are different clones that have the ability to potentially suppress the immune system or escape it in other different ways. And so it may be most useful to actually radiate the cold lesions. And so we hope to improve some of the benefit from that by targeting these cold tumors. And these efforts were supported actually by a philanthropy, and some people of you will know Ralph and Brenda Knapp, who were absolutely instrumental in this. Another theme is, instead of radiation, you can potentially use chemicals to do so. That's a group of drug that's has a mixed, or checkered history in clinical trial development, because you had to inject these into tumors. And so you could pick only 1 or 2 tumors, and then you often had to repeat injections, very difficult to do, quite expensive. And so, the idea was, can we potentially develop kind of like smart prodrugs to avoid these injections and deliver some of these to these tumors, again, with the thought of tumor heterogeneity, maybe radiating or injecting just 1 or 2 lesions not enough. What about inflaming all 10 lesions that we see in the body, right? So that's kind of like the thought where this would go. Can we target the tumor bulk? So one of the inspirations that we took is actually from a small molecule tracer. It's for PSMA. I don't know if you know, so it's prostate-specific membrane antigen. That's the name of the molecule. It's not prostate-specific, and I will show that to you in a second. But some of you may be aware that this is now an imaging modality in prostate cancer. And in fact, recently the FDA approved a radiation treatment for this PSMA lutetium-177. Again, on the left side, you see a small molecule that binds to the targeting of the PSMA protein. It's an enzyme. On the right, you see this weird ring with the M in it. It's a metal chelating moiety, and they can carry a radioactive molecule. And so some of the thoughts were, can we use this approach for kidney cancer? Now, kidney cancer cells themselves actually do not express PSMA, but curiously, in particular, clear cell kidney cancer, their vasculature expresses very high levels of this PSMA. And so if you actually take kidney cancer patients, and these are pictures of one of my patients when I was still at Hopkins, you can use the same trace that people use for prostate cancer to actually more with higher sensitivity, detect kidney cancer deposits than what you would find actually with just CT scans. And so this is actually data from a patient of mine who unfortunately died from kidney cancer, but he was very generous to do these scans before he died. And when he passed away, he allowed us to do rapid autopsy, collect tissue, and correlate that with the imaging studies demonstrating PSMA positivity, not only on the scan that we did, but also actually, in fact, in his tumors. And if you look carefully, you can see that, PSMA is more like a target that's not only relevant in kidney cancer. As you can see here, 11 out of 11 tumors carry this marker in the vasculature, but also other more common tumors such as non-small cell lung cancer, breast cancer, and many others carry that in the vasculature. And it's potentially almost like a pan-tumor target that we could use. So coming back to the molecule that's now, so to say, approved radioactive, but can we cut out the radioactivity and put a different molecule, so to say, to it? There are small molecules called toll-like receptor agonist, TLR, or STING. These are small molecules that if you put them into tissue, essentially you will ring the alarm bells of the innate immune system, cause a lot of inflammation, and cause attention of the immune system to that particular area. And so we developed some prodrugs that we are testing in animals that can actually do exactly that. You have the targeting moiety, and then you have kind of like these small molecules that would be cleaved off in the tumor system. It's a modular platform, and so we're working on some of these molecules. And in principle, it works that you have a cancer cell with the gray outline, and then you have these prodrugs. You have a target like PSMA here on the surface, and then these molecules bind to it. They go into small little vesicles, if you will, inside these tumors. That's where the target is. For some of these, they will be cleaved off and activated and cause inflammation. So this is just some of the data points. But again, I think the overall topic is, immunotherapy. How can we optimize treatments for patients and their outcomes? And so I will open up already to questions, because I think it's probably going to be the more important component for all of this.
Yes, and we've got some questions coming through already. Theta was asking, she says that she's a good responder to Sutent. And she's wondering if this indicates that immunotherapy may not work well for her.
That's a very, very good question. So I do think there is some truth to the fact that some of the particular angiogenesis-driven tumors, and if you've been on these drugs for a longer period of time, and maybe you're an outlier, in fact, with how long you benefit from them, these tumors tend to be less inflamed than some others. And so I don't think it's necessarily true, and should certainly not be taken as a disqualification, if you will, to consider immunotherapy in the future. But probably you're not going to be the average person when it comes to discussing some of the percentages of benefiting from it. I had a lot of patients who were, for quite some time on TKIs and then still had beautiful responses to immunotherapy. So it's not, it's such a complicated story, immunotherapy. I do think there's a trend to say that if you have, good risk disease with for example, pancreatic metastases and a lot of blood vessel formation, that your chance to respond is less. It's not going to be the, 42%. We already know that good risk patients respond only to 30% with nivo-ipi, for example, but there's a tendency to respond less well.
And then Brian was asking, is this doctor focused or patient focused? I'm not going to lie, some of that stuff at the end went over my head, but I think that it's important to understand, some of the work that you do, and this Q&A session is meant to be more patient focused. Deb's got a question here. Recently, we saw that Ipi-Nivo failed to offer any benefit in the adjuvant setting. Can you offer a potential explanation of why? But before you answer, I would like, if you wouldn't mind, to display what is the difference between immunotherapy and adjuvant immunotherapies?
So the immunotherapy is the same in both cases. It's just a different space. So adjuvant means, you had a tumor that was removed with some high-risk features typically, so often like stage 3 disease. And then various, more or less aggressive looking cells. And then your risk of recurrence for clear cell kidney cancer in particular is around 30 to 50%, depending on what the constellation is. And so the question here is, can we reduce the risk of recurrence right after surgery? And what you should also know is, and I think that will help the discussion, is that the principle of adjuvant therapy was actually not developed with immunotherapy drugs. It was developed with classic, chemotherapy that makes you lose your hair and depresses bone marrow, so classic poisons, if you will. And the observation there was, for example, in breast cancer patients, if you had recurrent breast cancer and you could see it, those chemotherapies did not cure these women, unfortunately. But if you gave them super early, meaning right after surgery, and you knew from the pathology that there would be higher risk for recurrence, let's say lymph nodes were positive, etc., you could actually cure some of these women, and you would improve overall survival for these women. And so that's how the field of adjuvant therapy was really born, and that has borne out for several other diseases to be working, like bladder cancer, lung cancer, colon cancer, etc. With the thought that, if you give it when you can see the cancer, you have so many more cells that you will typically always have some survivors. Now, with immunotherapy, to be honest with you, I think it's a very different animal, simply because we actually don't have the observation that we had with chemotherapy. You do cure some patients with overt, recurrent, sometimes even quite some large metastases. So either immunotherapy works or doesn't work, but it's not like restricted to necessarily to the amount of tumor burden that you have. So this particular observation makes it different than cytotoxic chemotherapy. And one of the questions is actually if we need to be necessarily in the adjuvant space. So do we need to give it super early or not? And I think, some of that is reflected in the data that we have in the adjuvant Keytruda trial, for example, where we do see, a delay in recurrence, but the overall survival so far is not really different. And that's in a trial that wasn't optimally designed, quite frankly, because a good number of these patients were treated in a different part of the world where they will never get immunotherapy. So we don't see an overall survival benefit yet. And so far, that might indicate that we don't follow the similar rules as with cytotoxic chemotherapy.
Staying on the topic of adjuvant therapy before we move on to the different topic, I know Deb had some other questions, being that the adjuvant Pembro from Keynote 564, why is this the only adjuvant immunotherapy trial to be positive so far? And why do you think it would be different? Will we see an overall survival benefit, in your opinion?
Yeah, so I don't know if you're going to see an overall survival benefit or not. I would say so far we don't see one. And if you look at a similar Keytruda trial, actually in melanoma, that was, by the way, better designed because it allowed every patient, even on the control arm, no matter where they were treated in the world, to get access to Keytruda if they progressed, which is different than the kidney cancer trial. And they don't also see an overall survival benefit yet. And that's now several years ahead. The difference here is it's fully accepted, I think, or largely accepted in melanoma, simply because if you progress on melanoma, it's much more fulminant. It's a much more aggressive disease than kidney cancer most of the time, where you have significant more lead time to find these lesions on imaging studies. I would say, looking at the whole landscape of adjuvant therapies, there's a trend that if you include more patients who are at lower risk, stage 2 disease, for example, you will have a higher chance of this trial not being positive. And we now have reports, if you will, not data presented, so I can only speculate, but what you hear through press reports or on the street, if you will, we have now 3 trials that actually are negative for adjuvant therapy with immunotherapy in kidney cancer. So about the Atezo trial, that's a little bit different because I do think that the PD-L1 inhibitors are a little bit less effective in kidney cancer. So that wasn't too surprising, but it's also, the word on the mouth, at least. We don't have an official report yet for the Prosper trial, which actually gave nivolumab before even surgery. Nivolumab and pembrolizumab, those two are PD-1 inhibitors. In my book, they are really very, very similar, same potency. I don't think there's much of a difference. But because you treated patients before you knew what the final pathology was, you probably treated too many patients with low-stage disease, and you would not see much of the difference there. Now, the Keytruda trial, Keynote 564, also included some metastatic patients. That's a special topic, but those patients are at very high risk for recurrence. And so how much that played into it to come to a more favorable outcome versus some of the other studies which did not, that's one of the question marks on this. Why, and coming back to Deb Maskin's questions, 914 was negative. That's very surprising because in my book, that's probably the most potent immunotherapy in 2022. So again, probably it's going to be patient selection. That's my best guess. But I think what it shows is, as a summary, if you will, that the adjuvant treatment with immunotherapy is not straightforward. It's not a no-brainer where the data is so clear that you should be treated as early as possible. And remember, with that approach, you also have some negatives. So let's say if you are the average stage 3 kidney cancer patient, you stand in front of the question of if you should do FDA-approved Keytruda or not. Let's say if you're just the average, low-grade stage 3, your chance of recurrence over 5 years is 30%, right? And you reduce the risk of recurrence by around 30%. So it goes from 30% to roughly 20%. So it doesn't work for everyone. And also, 70% of patients are cured with surgery alone. So you will treat 70% of patients with a therapy that probably roughly 1% of patients can experience death. On the trial, nobody died, but we know once you deploy it across populations and treat thousands of patients, there will be deaths, undoubtedly. And you will also cause irreversible end organ damage, in particular endocrinopathies, meaning hormone-producing organs will get wiped out. And I don't mean the thyroid gland, which happens in 20 to 30% of the time. That's easy to replace. I mean, adrenal insufficiency is much more complicated to replace, that we see in roughly 4% of patients. They had also type 1 diabetes. So So these are all, while in lower percentage ranges, these are, events, if you will, that have significant sequelae for these patients. If you're all of a sudden served with a brittle diabetes that can only be treated with insulin, it's a life-changing event, quite frankly. So, so I would say, personally, I tend to tell patients these both sides, and then patients will decide where they want to be and how aggressive they want to be. I think it makes more sense the higher risk you are. But you also need to think about the potential side effects. Also, surveillance is still an option. So it's not a mistake to just sit tight and be under the microscope with regular scans, and then treat with combination therapy at the time you recur, which might, by the way, be more effective than Keytruda by itself. So it's a very complicated discussion, and I think the negative trials don't help in terms of clarifying our opinion. It's just getting more complicated. But again, take everything that I just said with a grain of salt. I have not seen the granular data. I think there will be a lot of discussions in the field. We need to look at that very carefully and try to come up with a good understanding on how we should think about it, and try to explain it the best possible way to our patients.
Gotcha. And okay, so where do you stand on triplet therapies? And is it better to have these medicines administered all at once, 3 different forms of medicine at once, or is it better to sequence them?
These are very good questions. So as you know, there was a press release for Cosmic 313. There was a positive trial by progression-free survival, which was the primary endpoint. My answer is it'll depend on the patient. There are undoubtedly patients where I would love to have already triple therapy approved, simply because these are patients with high tumor burden, where I feel any progression would be or could be quite disastrous. And that's currently a situation where a lot of us would go into a PD-1 VEGF inhibitor, meaning pill and infusion doublet, simply because the response rate is so high. But I do think the immunotherapy component there might be less effective, at least for some of these. We have some follow-up data. They don't look as promising necessarily as nivolumab, ipilimumab. But the problem with nivo-ipi is that 20% of these patients will just frankly progress. And so then you can get those patients into trouble. So I'm not sure that if we get triplets approved, we should use it for everyone. I actually feel that we probably don't need to. But are there patients who would be better served with triple therapy upfront? I think there is no doubt about it. And in fact, there are some patients, when I sit in front of them and we have to talk about the different doublets, I feel strongly that there are some patients where I wish I had a triplet at my disposal. So I think it will depend on the patient and that particular situation. We also have to see, again, more granularity. How toxic are those regimens, et cetera. But, from my perspective, I think it's important to get effective immunotherapy into these patients up front. If I can stick with dual immune checkpoint inhibition by adding a TKI up front, that might be actually quite interesting to think about in some patients.
Ms. Parker asked, there was a slide in your presentation about patients who do and do not respond to immunotherapy. Mm-hmm. Would you mind elaborating on that and expressly what that slide covered?
Right. So the slide
the ability to share your screen again if you need to.
Yeah, it was one of the early slides, and the slide really was a tissue section. And on one slide where patients responded, you can see a beautiful immune infiltrate, some red spots among the blue. And on the other picture where patients really don't respond were just the blue cells. Now, this is a very, very crude way to think about it. In fact, doing staining for immune cells alone, doing staining for PD-L1 alone, is not really helpful on an individual basis to make the decision to give immunotherapy or not. So if your oncologist, for example, tested your tissue for PD-L1 staining, which is a marker for inflammation, and is negative, does not mean you shouldn't do immunotherapy. So the marker is not good enough on an individual basis. Now, if I take hundreds of patients and you look at the question, is the response rate in hundreds of patients higher if you're PD-L1 positive? That's true. So you can enrich those patients, but on an individual basis, these biomarkers are just not good enough to make a recommendation. So that's what I was trying to say is like, hey, get your immune system somehow. You're in a better boat starting off if your immune system is already engaged. So if your tumor is PD-L1 positive, I think it strengthens the resolve to engage with immunotherapy. But if it's negative, it does not mean you shouldn't do it. So we don't have perfect biomarkers. That was kind of like the background of the question.
What sort of things are you looking for to tell whether or not the immune system is currently engaged trying to fight the tumor versus not? What sort of things do you look for?
Yeah, so I don't necessarily look for it, but we do have, I would say, some clinical criteria where, it seems to be, that patients might be more sensitive to VEGF inhibition if you look at a large cohort than immunotherapy. So good risk patients, depends on the study, but I would say good risk patients have, they tend to be more angiogenesis driven. Again, not a reason not to give immunotherapy. I give even nivo-ipi to some good risk patients if they want to do it. It's in the guidelines, and if the insurance pays for it, it's fine. So it's just, what are the chances, right? And you go in with a certain, immunotherapy is really like, it's like playing the lottery. That's how I see it. It either works really well or it doesn't, and there's not that much, I think, in between. So the patients where we can stop therapy at some point, we feel they're cured, they typically have deep, uniform, early responses, and patients where it's just stable, I think they're at high risk of eventually progressing through it. You can identify some or give a sense for it by doing some of these clinical criteria for good risk, for example. Another group of patients, again, not a contraindication for immunotherapy, but if you have, tumors that are a lot of involvement in your pancreas, there's some interesting biology there that's probably more vascular driven than immune driven. And I would say, as a rule of thumb, it tends to be, interestingly, that the most aggressive tumors, such as sarcomatoid differentiation, for example, they have a lot of immune system involvement, actually. So if something is indolent, has been growing for years very slowly, it tends to be more angiogenesis driven, something that often is very aggressive from the get-go. The rule of thumb is a little bit more immune therapy and immune system involvement. Interestingly, you can do staining, but I don't use it to tell a patient, well, you're PD-L1 negative, you shouldn't do immunotherapy. It's just not the truth. For example, if you look at Checkmate 214, if you were PD-L1 negative, the response rate was 37%, and you still had a 7% complete response rate. So it's complicated. We wish we had a simple way to do it and advise our patients, but it's not that easy. Additional things that, again, are not widespread in use, for example, some of these PET scans. So in the one slide where we think about RADVAX2, we're going to use a small molecule from Bristol Myers Squibb to do essentially an immune PET, and where we look for PD-L1 expression across the tumor bulk and identify heterogeneity. So I think it's not only, the expression, but it's also, do these tumors all look the same? And if you get a response, it's going to be similar all across the tumors, or do you have really 10 different tumors and only one or two of those are inflamed and get destroyed by the immune system, the others are completely unimpressed? So it's not only just looking at a tissue, at one tissue, if you will, but also getting a sense for, Are these tumors all very different, or are they very similar?
Our next question from Brian, he's referring to an article, which I believe is this one here. If you guys should be able to see my screen, I think he's talking about this one, but Brian, if it's a different one, please let me know. But his question is, there was an article posted late last year regarding a treatment that saw some patients seem cured of RCC. Are you able to discuss the study further? I believe it was at UT Southwestern. So I think it's in regards to this one, where there was a new experimental drug that that was pivotal in the progression of clear cell carcinomas. The drug was able to turn off HIF2A.
Yeah. So yeah, no, I know what you mean. So it's actually not that experimental anymore. In fact, it's in phase 3 trials. Some of these are fully accrued in sporadic kidney cancers, meaning in most kidney cancer patients, in clear cell kidney cancer in particular. So waiting for some of the results. It's also part of the triplet therapy trial that I mentioned earlier, of the Merck trial. One of the arms has belzutifan, which is a small molecule that targets HIF2. And in fact, it's already FDA approved for patients with von Hippel-Lindau syndrome. So these are patients who have a genetic mutation, loss, or deficit in the von Hippel-Lindau gene. So they have kidney cancer that runs in the family, and they often have multiple bilateral kidney cancers. Also with other tumors that are driven by this mechanism, such as meningiomas. They have retinopathy with little tumors there. They have certain neuroendocrine tumors. And for those patients, it's FDA approved. It's been a game changer. I had a patient last week in tears because of happiness that all his tumors were like shrinking with extremely little side effects. The main side effect is low red blood cell count and some fatigue from that. So it's extremely well tolerated. I'm a little bit proud to say it came from UT Southwestern. I personally I didn't invent the drug at all, but it's just nice to see that from the institution here, people actually, identified the target, and then some geniuses in the biochemistry department thought about how to develop a small molecule to target, and then had a spin-off company called Peloton that Merck eventually bought up. But yeah, so belzutifan is coming. I think it's a real additional pillar in the treatment for kidney cancer. So far, we had blood vessel inhibitors, we have the immune checkpoints, and HIF2 is a molecule that goes after a transcription program. That's what I'm saying. It goes after how kidney cancer thinks. It's not just one target, it's really a transcription factor that allows the cell to turn on a stress program because it thinks it doesn't get the oxygen it needs. It's not a cure. I don't think of it as a cure. I do think it's a palliative therapy. The beautiful thing is it can work even in heavily pretreated patients quite nicely. So in sporadic patients, around 25% response rates. In von Hippel-Lindau syndrome is much higher because these are often more, genetically more pure tumors, if you will. And some of these responses can be going on for a long time. So it's certainly a molecule that we're all looking forward to.
Thank you for elaborating on that. That's fantastic news. I appreciate you sharing that with the audience today, Mr. Moran. So our next question comes from Ekaterina. She asks, says, we have RCC metastases with apologize, I'm going to butcher this, funca polymorphism, indicative of possible benefits of PARP inhibitors. Does it make any sense to include olaparib with other PARP inhibitors in the regimen in our case?
So what was the abnormality? I didn't fully get it.
She says that if you have RCC metastases with a funca, it's FANCA polymorphism.
Oh.
Indicative of possible benefit of PARP inhibitors. Does it make any sense to include olaparib or other PARP inhibitors in the regimen in our case?
Yeah, I would say, some of these options are not necessary to combine it with what's already FDA approved. I think you can approach, those thoughts, I would say typically, if there's not a clinical trial, typically if you run out of options, and then you can see if your insurance company wants to pay for that. Some of these, reports, they mention a lot of different things. They may or may not be as effective in kidney cancer, even with some of those mutations and in some other tumors. But I would say, it would be very reluctant to just combine things, especially if you're working. Especially if your treatment is already working. So I think that's something you would have to discuss with your healthcare provider and see when would be the right time to potentially consider going down that avenue.
And William asks, he says, I have been in IM Motion 10, or the atezolizumab and the Roche-sponsored trial for more than 5 years. Do you have any updates on this trial? Deb Maskins shared a link for this as well.
Yeah. So the Adjuvant atezo trial was negative. Well, first of all, let me tell you this. Thank you for participating, right? So because of patients like you, we find out what works or what doesn't work. And so to me, you guys are heroes and pioneers who are doing this, not knowing if it's going to work or not. These are all good ideas, but until we do it, we really don't know. And so first of all, thank you for participating. If it worked or had an effect for you personally, I don't know if you know which arm you were on or not. That's difficult to say. It's just because necessarily an endpoint was not reached does not mean there could have been personal benefits. There are patients who obviously benefit from atezolizumab and can get immune responses, etc. It may just be that the magnitude of benefit is not enough to fit the statistical design. It may be that that shows the wrong population, but there will be patients who benefit from it. So I do think it was an opportunity to get actually personal benefit. But yeah, so we have to see what the data is. None of us have seen the data. But it's always disappointing, but you should not be disappointed. First of all, it sounds like you're doing really great. You were, 5 years out, so to say, and doing well. And then again, just that you participated, I think you should be really proud of yourself for helping the field.
Absolutely. If there are any other questions, feel free to type them into the chat. We're coming to the end of our time here. Dr. Hammers, thank you so much for sharing your expertise today. It's been a wealth of information. I really appreciate you.
It's my pleasure.
Do you have anything coming down the pipeline that you're really excited about that you would like to discuss?
I think we're all waiting for some of these molecules. I do think the most palpable big new thing is going to be the HIF-2 inhibitor for sporadic kidney cancer. Again, it's already approved for von Hippel-Lindau syndrome. It's a great drug. And so I think that will be very interesting. By itself, I think hopefully it will beat everolimus. That was the trial design. Because that drug is uniquely well tolerated. It's also being evaluated in combination with other VEGF inhibitors. So I think that's the most palpable next big thing that will hopefully arrive as a treatment option for our patient.
Well, we're all looking forward to it. Thank you so much for your time today, Dr. Hammers. If anyone missed any part of today's conversation, it's going to be on our website on Monday. So you can check back on our website, on social media, or on our YouTube channel. We'll be posting it there. Thank you so much, Doctor. You have a great weekend.
It's my pleasure. Bye-bye, guys.
Bye, everyone.